I want to discuss in this and in subsequent talks QRS abnormalities. Those are basic ideas, but with a lot of advanced tips. When I look at QRS, I sequentially analyze the following 5 ideas. I look at QRS axis in the frontal plane, then I look for abnormal Q waves, then I analyze QRS width. Less than 110 millisecond is considered normal. 110 to 119 milliseconds is in the zone of incomplete bundle branch block or non-specific conduction delay. Over 120 milliseconds is in the zone of complete bundle branch block or more delayed non-specific conduction delay. Then I look at QRS height for LVH, RVH, or low voltage. Then, importantly, I look at R wave progression in the precordial leads, whether it's normal, poor R wave progression, or early R wave transition. There are a lot of specific and stylish tips to each one of those, and I will try to discuss those via case learning. I will start by focusing on numbers 4 and 5, QRS height and R wave progression in the precordial leads. Then in subsequent talks, I will discuss Q waves and QRS width. I will start with this. What's the diagnosis on this EKG? And again, I'm focusing on QRS abnormality. Can you tell me this patient clinical situation? Just by looking at this EKG, what's this patient clinical diagnosis? So this EKG shows a pronounced LVH voltage feature in the precordial leads, yet small QRS voltage, less than 8 millimeter in the limb leads. Whenever you see that big discrepancy, this is diagnostic of cardiomyopathy pattern or LV systolic dysfunction pattern. This is called the Goldberger criteria. So know that idea. Huge QRS voltage in the precordial leads, mainly the Sokolov and Lion, SNV1 or V2 plus RNV5 or V6 more than 35 millimeter. That's what was used by Goldberger. While QRS in the limb leads is less than 8 millimeter, is suggestive of a cardiomyopathy with low EF pattern. The cardiomyopathy could be ischemic or non-ischemic. That feature also may apply in patient with or without left bundle branch block. And this is the paper by Goldberger that validated this. It's a very specific feature, not very sensitive in modern registries. It's about maybe 20% sensitive. In my experience, it's quite common. I see it at least a couple times a week. Now, when you look at this, can you tell if it is ischemic or non-ischemic cardiomyopathy? Ischemic cardiomyopathy frequently are characterized by one big features. What is that one big feature? Q waves. About 70% of ischemic cardiomyopathies have Q waves. So when you see this pattern with no Q waves, it's more likely in non-ischemic cardiomyopathy. Now, I see something else on that EKG. He has biatrial enlargement. Look at P wave in lead V1, big positivity up, big negativity down, big right atrium, big left atrium. Here in lead 2, high P, big right atrium, wide P, big left atrium. That also supports that diagnosis of biventricular failure with probably 4-chamber enlargement. I see something else. He's in sinus tachycardia. So I can already, by looking at that EKG, make the diagnosis. This is a patient with low EF, likely non-ischemic cardiomyopathy, who's presenting with decompensated heart failure, maybe pre-shock, maybe full-blown shock, just by looking at the EKG. That's how valuable EKG can be. I want to explain, that Goldberger criteria. I mean, why do you have high voltage in precordial leads, low voltage in the limb leads? When you have a dilated heart, the muscle becomes close to the surface, to the ribs, and therefore to those precordial leads. So you get high voltage in those precordial leads. In the frontal plane, the limb leads, the heart moves posteriorly. The more it enlarges, the heart axis of depolarization moves posteriorly. So on the frontal plane, that heart axis moves more and more almost in a sagittal plane. So it becomes orthogonal to those leads. Therefore, the voltage in those limb leads become attenuated. Also, those patients with decompensated heart failure, they have soft tissue edema, which attenuates the transmission of voltage to the limb leads, not so much to the nearby precordial leads. This is another EKG. Could you tell me what's the diagnosis on this EKG? You have the same thing almost. So you have LVH voltage, mainly because of the precordial leads, whether Cornell criteria, RNAVL plus SMV3, or the Sokolov and Lyon. You can do SMV3 plus RNV5 more than 45 millimeters. So you do fulfill high voltage in the precordial leads, relatively low voltage in the limb leads. So again, you have a cardiomyopathy pattern on this EKG. LVH with a dilated cardiomyopathy pattern. So like I mentioned, 8 millimeters is what was used. To call it low voltage in those limb leads, the true definition of low voltage is less than 5 millimeter in the limb leads, 10 millimeters in the precordial leads. But for that criterion of Goldberger, they used 8 millimeters. So you're almost there, except in that lead, you're a little bigger than 8 millimeters, but you almost fulfill it. You have the spirit of it. So big voltage precordial leads, relatively low voltage in the limb leads, mostly less than 8 millimeters, suggestive of cardiomyopathy. Now, here you can tell it's not just cardiomyopathy pattern. You also have inferior Q waves and maybe septal Q waves. So this EKG is suggestive of not any cardiomyopathy pattern. It's ischemic cardiomyopathy. It is the LV systolic dysfunction pattern or cardiomyopathy pattern with ischemic features. So this patient likely has ischemic cardiomyopathy. I'll move to simpler diagnosis. What does this patient have? And here I want you to recognize what are the LVH voltage criteria. The point of this EKG is that I see a lot of fellows not knowing the voltage criteria of LVH. You absolutely need to know the voltage criteria of LVH. There are 37 criteria. You need to know at least the 5 most common ones. And that EKG has a lot of them. This is how the heart is displayed in a frontal and in an axial plane in a normal person. The gray is the axis of depolarization of the heart. The blue are the septal depolarization. Okay? So usually this is how electrical depolarization spreads in the heart. You start with the septal depolarization, the blue one, which gives you that initial small normal Q waves in some of the leads, like lead 1 and the lateral precordial leads. Then you spread across the main myocardial axis, the gray one. Then you depolarize later on the base of the heart, the black one. And the way each vector projects give you the QRS morphology in any particular leads. This is from my book. You can review that. Now in LVH, the heart is shifted upward and leftward in a frontal plane. That makes those forces more pronounced in lead 1 and AVL. The heart is shifted more posteriorly and leftward in an axial plane. That gives you big S waves and negative waves in the right precordial leads and big positive waves in the left precordial leads. And that will give you all those LVH voltage criteria, which you need to recognize. One, you have R and AVL more than 11 millimeters, assuming standard calibration, which you can see here. So R and AVL more than 11 millimeters. R in 1 more or equal to 15 millimeters. R in 1 plus S in 3 more than 25 millimeters. You need to memorize all those. And they make sense based on the axis shift I explained. Then the single most important one that a lot of fellows don't know is Cornell. You need to memorize that very well. S in V3, which is here, you know, big negativity in those right to mid precordial leads. So S in V3 plus R in AVL, S in V3 plus R in AVL, more than 28 millimeter in men, which is 5.5 boxes, and more than 20 millimeter in women, which is more than 4 big boxes. And actually, Cornell, if you have a big T wave in lead V1, more than 2 millimeters, you can reduce those cutoffs. Instead of 28 to 20, you can use 22, 12, 22 in men, 12 in women. It is the most sensitive voltage criterion for LVH. So please, Cornell, know it very well. Another one is what we call the Sokolov and Lyon criterion, which is S in V1 plus R in V5 or V6 more than 35 millimeters or 7 boxes. Okay? And this is a listing of those criteria, okay, that I just described. You can also use a modification of Sokolov and Lyon, which is S in any precordial lead plus R in any precordial leads more than 45 millimeters. 9 boxes. Now, one comment regarding Q waves in V1 and V2. I will explain that a little later. Q waves in V1 and V2 may suggest a prior septal infarct, but they are not specific. They are a septal infarct in about 20% of the time. Most often, they are not septal infarct. Most often, they are like poor precordial R wave progression, suggestive of either LVH, left bundle branch block, or issues with lead placement or left anterior fascicular block. So it's a good point that you have a QS in leads V1 and V2, but it's not very specific for infarct. And this is from a paper in 1985 that validated the Cornell criteria as being the most sensitive criteria for LVH, and it compared them to some other features. This is another more modern paper. This is another EKG. I hope you can all see it's another application. You have, again, LVH voltage criteria. You do fulfill Cornell here. This is a woman, and you are over 20 millimeter. R in AVL plus S in V3 is over 4 boxes. It's over 20 millimeters. You have R in AVL more than 11, R in 1 more than 15, R in 1 plus S in 3 more than 25 millimeters. You do not fulfill the Sokolov and Lyon in this patient. Note, like I described earlier, the more you have cardiomyopathy, the more you'll have bigger voltage here, lower voltage there. Your voltage criteria for LVH will be driven by the precordial leads. Now, another idea that is important for board and for coding and reading EKGs. Can you diagnose LVH in the setting of left bundle branch block? Clinically, yes. Most left bundle branch block have LVH. 80% of left bundle branch block have LVH. However, for coding purposes, once we say left bundle branch block, we do not say LVH. And in the board, they don't want you to code LVH in conjunction with left bundle branch block. Now, as a fellow, I used to always wonder, well, can I code incomplete left bundle branch block with LVH? The answer is yes, and actually you should. LVH can be diagnosed with incomplete left bundle branch block. In fact, incomplete left bundle branch block is frequently a natural progression of LVH, and you should code it if it is present, and you should recognize it if it is present. You should recognize that progression. This is the natural EKG progression of hypertensive heart disease. You start getting progressively more and more LVH voltage. Then you start having LVH with a strain, like on those EKGs. He's starting to have STT abnormality opposite to QRS. You get ST depression and T inversion opposite to QRS. You get ST elevation in leads where QRS is down. The ratio of ST elevation to QRS remains less than 20%. So you start getting more strain pattern, STT abnormality. That's part of the progression. Then you start getting widening of that QRS. You start getting incomplete left bundle branch block. And this is how we diagnose incomplete left bundle branch block. It's over 110 millisecond QRS with loss of Q wave in 1N AVL. Normally, you have that tiny Q wave in 1N AVL, that septal depolarization Q wave. Well, when you have left bundle branch block, your septum doesn't depolarize anymore left to right. It depolarizes right to left, so you lose that septal Q wave. And actually, that's your earliest hint to incomplete left bundle branch block. You may not have a slurred R wave because the QRS is only 110 milliseconds, but you will lose that Q wave in 1N AVL with a QRS over 110 milliseconds. Then the ultimate stage of hypertensive heart disease is complete left bundle that's progressively wider with larger precordial voltage and more pronounced STT abnormality. And the wider it is, the more fractured it is, the more you're reaching a stage of progressive LV systolic dysfunction. The more you progress through those 4 stages, the more you're having progressive LV diastolic and systolic dysfunction, and the more you're having heart failure. So by looking at an EKG, you can almost guess whether this patient will have a clinical heart failure or he's at risk of clinical heart failure, and you can start to guess how his EF is declining. Now, I want you to know most left bundle branch block is a reflection of underlying myocardial disease, unlike right bundle branch block, which is most often a pure conduction disease. Most left bundle branch block is reflective of underlying myocardial disease, and the most common one is not ischemic. The most common one is a hypertensive heart disease combined with some degenerative conduction disease, with or without low EF eventually. The wider that left bundle, especially over 150, the more likely you are to be at a stage with low EF. More than 180, it's highly likely that you have low EF at that stage. Okay, and the more you have that cardiomyopathy pattern, big QRS precordial, low QRS limb leads. And the more you have SCT abnormality, and the more fractured, the more notched that QRS, the more likely you have a low EF with it. You can almost tell when left bundle is predominantly driven by hypertension versus when it's predominantly driven by conduction disease. When it's predominantly driven by hypertension, you have more pronounced voltage in that left bundle branch block. And you may start getting wider and wider QRS because you have myocardial disease. When it's pure conduction disease, it's usually not as wide and not as rich from a voltage standpoint. I want to give a couple of additional ideas regarding LVH. Left axis deviation less than minus 30 degrees is actually infrequent with LVH. You frequently have leftward axis, 0 to minus 30 degrees, but not full-blown left axis. Unlike RVH, where right axis deviation is mandatory. In fact, when you have full-blown left axis with LVH, you should be thinking of associated left bundle branch block if the QRS is wide, or left anterior fascicular block if the QRS is less than 110 or less than 120 milliseconds. In fact, LVH plus left axis should make you consider left anterior fascicular block if the axis is less than minus 45 and QRS is less than 110 to 120 milliseconds. Another important idea is it is widely thought that LVH voltage criteria are not specific in patients less than 35. That's because patients less than 35 are slimmer and they have less epicardial fat, therefore less attenuation of their QRS voltage and more pronounced QRS voltage, making the voltage criteria less specific. However, modern data suggests that those voltage criteria remain specific in the young, particularly Cornell and AVL lead criteria, and even the Sokolov and Lyon, which loses some specificity in the young, but remains fairly specific, as in this paper. This is partly because the younger population is becoming more obese, Therefore, more attenuation of the QRS voltage and more LVH and more hypertension as well. Now, LVH voltage criteria are likely not specific in the young, less than 35, who is also slim and athletic. So in the athlete young, they are not specific. And in that subset, you need additional features to support the diagnosis of LVH, such as any of the following: a leftward or a full-blown left axis, especially that the young and slim tends to have a vertical axis. So a horizontal or leftward axis supports LVH. Or STT strain pattern of LVH, or left atrial enlargement, or QRS widening 1/10 millisecond or more, or notched fractured QRS even within the normal zone 100 to 110 milliseconds. Or poor precordial R progression or late QRS transition in V5. This is another EKG. Can somebody read it for me? That QRS, let's say, is 115 milliseconds. LVH, QRS widening, and loss of Q waves in 1 and AVL. So this is incomplete left bundle branch block as part of the natural progression of LVH. What else? Don't forget, when we analyze QRS, we analyze height, width, axis, R progression in the precordial leads, but also Q waves. I always start by looking at Q waves. You have a pronounced inferior Q waves. What else? You have a Q wave in V4. You have even more things on this EKG. So you have inferior infarct, anterior infarct, LVH, incomplete left bundle branch block. To summarize, here is what we have. One, we have extensive Q waves. We have inferior Q waves, wide more than a box, and deep more than one box, and actually deeper than a quarter of R in this lead 3. So inferior Q waves. We have poor precordial R progression with a Q wave in V4. This is a definite prior anterior infarct. So old inferior and old anterior infarct. You also have LVH voltage criteria. You have S in V3 plus R in AVL over 20 millimeter or 4 boxes in a woman. You also have a QRS widening. That QRS is approximately 110 to 120 milliseconds. Along with that, you have loss of Q in 1 and AVL, and that suggests incomplete left bundle branch block. You also have some notching of R in lead V6, again, in context suggestive of incomplete left bundle branch block. So this is what you have, basically. You have old inferior and anterior infarct, you have LVH and incomplete left bundle branch block. In this case, secondary to ischemic cardiomyopathy rather than to hypertensive heart disease. You have ischemic cardiomyopathy, you get dilated LV, low EF, and with that, you get LVH voltage criteria and left bundle branch block. Keep in mind, LVH voltage criteria mean an increase in myocardial mass. But the increase in myocardial mass does not mean concentric LVH. It could be an increase in myocardial mass from eccentric LVH that you get in a dilated myocardium, as in ischemic cardiomyopathy or dilated idiopathic cardiomyopathy. Another idea is that LVH doesn't just reflect myocardial mass, it also reflects LV size, cavity size, LV dilatation. That can give you LVH as well. So in this particular patient, LVH is driven by eccentric hypertrophy and LV dilatation itself. It's not the concentric hypertrophy of hypertensive heart disease. And you can tell by looking at the EKG. You can already tell this patient has low EF from an ischemic cardiomyopathy. An important idea here, when you have complete left bundle branch block, the Q wave criteria for infarct become less specific. And I will explain that. I have left bundle branch block coming at some point in a second talk. So if this was a complete left bundle branchial block, then saying anterior infarct based on that Q wave would become less specific. There are ways of diagnosing an infarct in left bundle branchial block. So left bundle branchial block gives you Q waves, but it gives you a certain pattern of Q waves. For example, left bundle branchial block does not give you QR pattern. It can give you in the inferior lead the QS pattern. So a deep QS, it can give you here a QS pattern, something like that. It does not give a QR. QR, even with complete left bundle branchial block, is definitely an infarct. Then there are also other criteria that I will explain later, such as when you have a Q wave infarct, the upslope of the R wave in leads 1 and AVL may become notched or fractured, as is actually the case here. In conjunction with left bundle branchial block, that can indicate an infarct. Also, the upslope of the S wave in leads V3 to V5 may become fractured. That's not the case here. But at the very least, realize that yes, left bundle branchial block can give you QS pattern in some leads inferior and anterior. However, it does not give you a QR pattern. And left bundle also doesn't give you Q in some leads. So with left bundle branchial block, as I explained, you lose the lateral Q waves in 1 and AVL. That's part of the definition of left bundle. You lose the Q wave in V5, V6. So if you have what looks like left bundle branchial block, wide QRS with notched R wave, yet you have a Q wave in 1 and AVL and V5, V6, you can call this a left bundle branchial block with a prior lateral infarct causing Q waves, or you can call it atypical left bundle branch block. And the reason it's atypical and the reason you didn't lose the Q wave is that you have a prior infarct in those leads. What is poor precordial R wave progression? I want you to know, this is a term that is commonly used. I want you to know exactly what it is. It means the actual definition is R wave height remains less than 3 millimeters, 3 small boxes in lead V3, and more specifically, the one I use, less than 1.5 box in lead V3, with failure of the RS height ratio to increase, meaning S remains very deep. Sometimes this is accompanied by QS in V1, V2, which is what I mentioned earlier. QS in V1, V2 with the present R wave in V3 is not definitely an infarct. It's more in the realm of poor precordial R wave progression in terms of its differential diagnosis. This is an illustration of a small R wave in V1 through V3 that remains less than 1.5 millimeters in lead V3. This poor precordial R wave progression may be an equivalent of Q wave and may signify an anterior MI, particularly if one of the following two features coexist. The idea here is that most poor precordial R wave progression are not MI. Most of them are lead placement or heart position in relation to the leads. For example, if leads V1 to V2 are placed higher up, they are placed second intercostal space rather than fourth intercostal space, they will be too high in relation to the heart, and therefore the heart will be looking away from them, and you will have a negative. You will have a tiny R, big S, or full-blown QS in V1, V2. Or in patient where you're placing the V1, V2 in the fourth intercostal space, but they have an elongated chest, like a COPD patient. The heart is pushed down, or they are slim and tall, the heart is pushed down. And those patients will have poor R wave progression that is related to that relationship between the position of V1, V2 and the position of the heart. Also LVH, lung disease, left bundle, all those can give you poor R wave progression. So how can you tell it's an infarct? Anterior infarct can give you that. In practice, overwhelmingly, poor R wave progression is not an infarct, but you need to distinguish, can it be an infarct? And the way you can tell it's an anterior infarct, it's a sequelae of an anterior infarct, is T inversion in V1, V3, or R wave in lead 1 plus or minus in lead V5, V6 remains very small. So it's not just poor R wave progression, it's R wave in the lateral leads that remains diminished. Not in this case. For example, this case has really very poor R wave progression, even up until V4, but I can tell you this patient is unlikely to be an infarct. His R wave is still quite big in the lateral lead. You know, usually when you have an anterior infarct, you will have some lateral extension. That's why you will have diminished R in those leads and in the lateral leads, 1 and AVL. Or you may have T inversions in V1 through V3. So having those two features are supportive of prior infarct. Conversely, the following two features argue against an MI. Improvement of R wave progression with lower placement of the chest electrode, because like I said, it could be related to a lead placement in relation to the heart. But very importantly, this, you have an abrupt change in R wave in V4 to V5, meaning you jump, you have poor R, then all of a sudden you jump, boom, to a big R, much bigger than S in one lead. That suggests it's not an infarct. If you have an infarct, you're not all of a sudden going to get a big R wave in an adjacent lead. It will be a very slow progression all the way throughout. So in this patient, having an abrupt rise in one lead tells you, well, maybe there is an issue with lead placement. Maybe this is a patient with large breasts. Maybe this is a woman with large breasts. So some of the leads are placed too high up, those V1 through V3. Then at one point, the leads are placed down and they captured a true LV depolarization. So that abrupt change between where you have a small R to big R is suggestive that it's not an infarct. Also having a good transition in V4, like your R all of a sudden is bigger than S in V4 or much bigger than S in V5, that also suggests it's not an infarct. You will hear also the term reverse precordial R progression, meaning it's not just that R doesn't grow between V1 and V3, it grows in reverse. It gets smaller between V1 and V3. It's really the differential diagnosis is not much different than poor precordial R wave progression. It doesn't make it more likely to be an MI. So know the criteria that suggest this is an infarct, that poor R wave or reverse R wave progression. It is truly an infarct based on those two. Know the idea that argue against it, especially that abrupt, sudden transition in V4 or V5 with an R significantly bigger than S. Now be careful. Having abrupt transition in V4 or V5 argues against MI, but not having it does not mean MI. Meaning you can have poor R wave all the way to V5 or even V6, and this does not mean MI. Poor R wave all the way to V5 or V6 with no transition to big R may be seen with many other causes, like left anterior fascicular block, LVH, left bundle branch block, or lung disease, all of which cause the heart axis to be swung posteriorly away from those precordial leads, which will cause poor R wave progression in those leads, sometimes even all the way toward V6. And those are the causes of poor R wave progression: left anterior fascicular block, LVH, left bundle, high misplacement of electrodes V1, V2, or low heart, low diaphragm position in thin and tall individuals, or heart swung posteriorly away from those precordial leads, as may happen in older subjects, in LVH, or in COPD, where the heart, because of the chest air, is pushed more posteriorly. And keep in mind, poor precordial progression is most often not an MI. In fact, among patients with normal heart at cardiac catheterization, based on one study, the EKG showed poor R wave or reverse R wave progression in 7 and 1% of patients. That's a huge number, very common. Even when it's a sequelae of an old anterior MI, the MI is usually non-transmural, versus it is transmural if you have a full-blown QS all the way in those leads. So even when it is an MI, it's a better MI than having a full-blown Q waves. It's important to understand those subtleties because you can already make a diagnosis and risk stratify the patient prognostically by looking at the EKG. So this EKG that we looked at earlier, it's unlikely to be anterior MI. He has poor R wave progression. He has a QS in V1, V2, and the R in V3 is, 1.5 millimeters. But he has quite a big R, bigger than S in V4, V5, really big R waves in V5, V6, especially more than one big box, much more here. And really R wave bigger than 4 millimeter in lead 1, way bigger than 4 millimeter, actually LVH in lead 1 and in AVL. So this is not an anterior MI, I can tell you. The same thing here. Again, QS in V1, V2, poor R wave progression, but really big R waves in V5, V6, and in 1 and AVL. This is not an anterior MI. And this is, by the way, poor R wave progression in those latter two EKG due to the LVH. That's what's giving you the poor R wave progression and the QS in V1, V2. The heart is moved away from those V1, V2. So we end up getting that tiny R, big S in V1, V2. But at one point, you can even lose the R depending how far the heart axis of depolarization is from that V1, V2. This one, on the other hand, this is poor R wave progression, very poor R. You see R in V2, V3, it's extremely small. But then, conversely, as you progress, you're having a full-blown Q wave in V4. So when you have a Q wave in V1, V2, I told you it's not very specific for an infarct. A full-blown Q wave in V3 is specific for an infarct. There is still a chance, maybe in the range of 20%, it's not an infarct, but your specificity is reaching 80% or so when you have a Q waves all the way V1 through V3. But when you have a Q in V4, this is 100% of an infarct. Okay? So this is poor R wave progression with a Q wave in V4. This is 100% of an infarct. Let me show you this EKG. Look at this EKG and tell me what's the diagnosis. Be specific. Is it poor R wave progression or there are Q waves? When you say Q V1 through V3, that's exclusive of poor R wave progression. That we call this Q in V1 through V3. So there is an R in V1, V2, and V3. It's a small R. It's a very poor R wave progression. Even in V4, the R is very small. It's one box. So it's poor R wave progression extending to V4, and even in V5, the R remains less than S. So it's definitely poor R wave progression. Now, is this MI? Let me clarify. If the QRS goes up abruptly in one of the leads, and you have a big R wave in one of the leads, much bigger than the S, that argues against an infarct. You can comfortably say this is unlikely to be an infarct. However, if you don't get that abrupt rise in R, that doesn't mean it's an infarct. You understand? So having an abrupt rise in R tells you it's not an infarct. But not having it, meaning the R remains sluggish all the way, doesn't tell you it's an infarct, because actually a lot of those don't give you an abrupt rise in R. In left anterior fascicular block, the electrical depolarization is shifted posteriorly. So you have poor R wave progression and small r, big S, all through the precordial leads. LVH, left bundle, LVH and left bundle, the electrical depolarization is shifted posteriorly. So again, you'll have small r, big S in all the leads potentially. In some of the patients with LVH with a really large heart, everything is shifted posteriorly. So you actually don't get big R in the precordial leads V6, V5, V6. You'll have to go to V7, V9 to get big R. Same with left bundle in a big heart. Same with COPD. COPD pushes that whole heart posterior, so you get sluggish progression throughout the leads. So not having an abrupt R doesn't tell you it's an infarct. Having it is great, but not having it is not helpful. It could be one of those. Basically, not having it tells you it's not a normal pattern. It's not this one here, high misplacement. but it could still be any of the other ones. This poor R wave progression is suggestive of an infarct, mainly because the R in one is small and the R in AVL is small, and you actually possibly have a Q wave in lead one, and you definitely have a Q wave in AVL. So this is really suggestive of an anterior and lateral infarct. So that's why this poor R wave progression here, you don't have any Q anteriorly, but that poor R wave progression in conjunction with what you find in those limb lateral leads is suggestive of a prior anterior infarct. But I'll make it more complex. I'll tell you this is not an anterior infarct. And actually, when I read it, I kind of recognized it. I dug through the chart and I confirmed it. There is a second differential diagnosis when you see this EKG. What's another differential diagnosis? In that list of poor precordial R progression, there is no LVH on that EKG. There is no left bundle branch block. There is no left anterior fascicular block, which would be in a left axis less than minus 45. That's not the case. You have a right axis here. You're, equiphasic in one and positive in AVF. So you have a right axis. So you're not any of those three. Can you be this one? COPD.
You can argue that there is RSR prime pattern in
RSR prime with a QRS less than 110 milliseconds can be a perfectly normal pattern. So RSR prime with a QRS less than 110 milliseconds and with an S bigger than R and R prime is a perfectly normal pattern. So that will not help me here.
Look like there's right atrial enlargement also. That would help you with COPD.
Very good point. That could help. Absolutely. In leads 2 and 3 and AVF. Yes. So I just want you to think when you look at this EKG, yes, think this is very possibly an anterior infarct. But this could also be COPD, where the heart is swaying posteriorly. Hence, you have a prominent negative forces throughout all of the precordial leads or most of them. And that's why with COPD and lung disease, you will get a right axis because the heart is swung vertically. And that would explain the right axis. Typically, you shouldn't get Q waves, but on occasion, you can get Q waves in the lateral lead, especially in lead AVL. You can get a Q wave in lead AVL in patients with a vertical heart. So when I looked at it, I thought this could be COPD. Another hint for me for COPD, the QRS in all leads is just not large. It doesn't fulfill the criteria for low voltage, but in those precordial leads, you do fulfill the criteria for low voltage. So the idea of low voltage in some sets of leads suggested to me this could be COPD, not just an MI. Although with MI, you can have low voltage. The same way I explained the cardiomyopathy pattern where you have low voltage in the limb leads. At one stage, if you have a cardiomyopathy, especially ischemic cardiomyopathy with a lot of scar tissue, you can lose voltage everywhere. So you can have diffuse low voltage in end-stage cardiomyopathy awaiting transplant. So low voltage doesn't necessarily argue against anterior MI, but it makes you think, well, this could be COPD. Eventually, this patient, that's what she had. She had really advanced COPD with a normal EF. This is another EKG. What's the diagnosis on this EKG? So we have poor precordial R wave progression, very small R in V2, V3. Is this MI or not? We have T inversion in V1 through V3, clear-cut T inversion. And we have tiny R in lead 1, less than 4 millimeters, and tiny R in AVL. And indeed, this patient did have apical akinesis. How about this EKG? This is another poor R wave progression. This one is extending all the way to V5. What suggests here prior anterior MI is you have Q waves in the inferior lead. So you already are thinking ischemic cardiomyopathy. So the same way you have inferior infarct, maybe this is an anterior infarct. And actually, it's probably an anterior infarct of an wraparound LAD that gives you inferior Q waves. So seeing this tells me it may very well be this in anterior infarct. Now I think the R wave in 1 and AVL, they don't fulfill the 4 millimeter criterion, but they are fairly small, especially in AVL. This is suggestive of an anterior MI. And indeed, this patient does have apical ekinesis on his echo. Now, this is far more likely to be a non-transmural infarct and a viable infarct compared to full-blown Q waves anterior MI, full-blown QS wave between V1 to V4, V5.